Good evening, everyone. Today, I'll be speaking about essential pitfalls in the diagnosis and management of essential as well as dystonic tremors. So my plan of talk will be, initially we'll briefly discuss the recent tremor classification of 2018, then we'll go through essential tremor, then ET plus and its issues, and then dystonic tremor. So we'll start with the definition of tremor is that it is an involuntary rhythmic oscillatory movement of a body part. So classification of tremor of 2018, they have divided into two clinical axes. Axis 1 is for clinical features and axis 2 for etiology. So if we see in axis 1 clinical features, they have divided into four categories. First is historical features like age of onset, temporal evolution, is there any family history, responsiveness to alcohol, then characteristic of tremors in terms of frequency of tremor, activation condition, body distribution, like whether it is focal or segmental or generalized, and whether there are any associated signs are there or not. Accordingly, tremor can be divided into two, either it is isolated tremor or combined tremor, likewise dystonia. And then additional laboratory testing like electrophysiological testing, imaging, and etiology in axis 2 has been divided into three categories: acquired, genetically defined, and idiopathic. So this is the tremor characteristic. Age of onset, accordingly, similarly they have divided according similar to dystonia into various age group. Anatomical distribution can be focal, segmental, hemitremor, generalized. Tremor frequency, they have roughly divided into less than 4 Hz, 4 to 8 Hz, 8 to 12, and more than 12 Hz. If we see the activation characteristic, then mainly tremors have, they are divided into mainly two types: rest tremors and action tremors. Action tremor can then be subdivided into three types like kinetic, postural, and isometric. So kinetic tremor again can be of simple kinetic tremor that is present during the whole action only while reaching the goal object, that is intention tremor, and particularly during specific tasks, then it is task-specific kinetic tremor. Postural tremor can be position-dependent or position-independent, and isometric tremor is when tremor appears while against a stationary object while making a fist. So that is an isometric tremor. And they then tried to divide tremor into various syndromes according to this characteristic, like whether it is action or rest tremors, then it can be ET or ET plus, isolated rest tremors, isolated segmental action tremor, enhanced physiological tremors, then focal tremor like head or voice tremor, essential palatal tremor, then task-specific tremors, orthostatic tremor. And this is an important group, that is tremor associated with additional signs like whether there is a presence of dystonia, Parkinsonism, ataxia, or any other. There is myarrhythmia, symptomatic palatal tremor, and then there are functional tremors and indeterminate tremors. Yes. No. If both upper limb tremor, then it will go into isolated segmental action or postural tremor because it will become segmental according to body distribution. And if the suppose if a patient has contiguous body parts, yes, like dystonia only, and if a patient has duration of less than 3 years with both upper limb action tremors, then they say that we cannot say ET, but then they have classified this indeterminate tremor etiology till any cause is found. Some essential facts, like it is the most common movement disorder seen in neurology clinic. Prevalence overall is about 0.5 to 1%, but it increases after the age of 65 years. There is no gender difference in prevalence. And we all know that there is bimoral age distribution first in the second or third decade. And it is more, those patients are more likely to have positive family history and alcohol responsiveness. And second age distribution in 6 to 7 decade, and they are more likely to have presence of dementia if particularly starts after the age of 65. So what is the definition of essential tremor according to recent guideline? So it is an isolated tremor syndrome. The important word is isolated of bilateral upper limb action tremor. Another word is action tremor. Second is at least 3 years duration. The third necessary thing is with or without tremor in other locations like head, voice, or lower limb. But upper limb tremor should be present. And absence of other neurological signs such as dystonia, ataxia, Parkinsonism. So it ultimately becomes isolated tremor syndrome. And there are some exclusion criteria for ET. Initially, isolated focal tremors like head and voice tremor were classified into ET according to older classification. Now they have considered both of this into exclusion criteria, because now more and more evidence have come that feel that isolated head and waist tremors are more of dystonic tremor quality. The other exclusion criteria is orthostatic tremor with frequency of more than 12 Hz. Task and position specific tremors like primary vibrating tremor. Similarly, now it is more considered as a dystonic part of dystonia. And the sudden onset and stepwise deterioration is also an exclusion criteria for ET. Clinical characteristic of tremors in ET, if we see, the main component of the tremor is kinetic tremor. And amplitude of kinetic tremor is more than postural tremor. Usually frequencies between 4 to 12 Hz. Usually mild asymmetry is seen between two arms. Postural tremors have certain characteristics like amplitudes are more in the wing beating position as compared to forward arm extension, and the tremors in both hands are out of phase due to lack of phasic synchrony. So when the patient tries to hold any glass or cup with single hand, then he or she will get tremor. But if he tries to hold with both the hands, then it will he must not be having that much difficulty as compared to a single arm. So that is out of phase, and greatest amplitude is at wrist and in flexion extension movement. Rest tremors in ET are also found in 20 to 35% of cases. It is only found in arms. And with the progression of ET, there is a spread of tremor to cranial structures over time, like neck and jaw and voice. And it is more common in women with ET, particularly neck tremor.
Doesn't fit into definition.
Yes, that I will come through that. Now, rest tremors in ET is considered as ET plus according to this classification. But overall, the data is like that rest tremor over long time can occur in patients with ET. So that is one controversy of this classification of ET plus. So here we'll see the video of a patient. So this patient is a 44-year-old male with a history of tremor in both hands for last 15 years, mainly action tremors, and positive family history of tremor in father, grandfather, brother, paternal uncles. So if we see here, there is some rest tremors in right upper limb, but there is not much resting tremor in the left upper limb. But now if we see that now postural tremor, so we can see there is an asymmetry, right more than left. And this is a commentable thing, whether to consider this as mild dystonic posturing or not is a subject of debate. But considering the history, long-standing history, 15 years history of tremors, and there is no position-dependent change in the frequency of tremors, it remains the same. We can see there is kinetic component of the tremor in the left hand, which was not there much in the postural forward arm extension, but it is more on the right side. Yeah, there is kinetic tremor. MRI brain is normal, so what should we consider? Diagnosis ET or ET plus? Familial? ET, yes. This is a patient with familial ET with multiple family members in 3 generations. Yeah. Over long term, so the point here is, sir, is that over the long term, 15 years history, mild rest tremors, mild dystonic posturing is allowed in patients with ET. If there is a shorter duration, like maybe 2 years or 1.5, 2 years, 3 years, then it is still a debatable. Yeah, head tremors in ET are usually unidirectional, either yes or monotype. It resolves on lying down in the bed with head at full rest. So the tremors of head are action tremors in ET patients. And there is often agnosia for head tremors, that patients are sometimes being unaware of the tremors, particularly when it is mild. And there is no head tilt or rotation, no null point or sensory trait. There are some non-motor features of ET that data are coming increasingly day by day, that those features develop as the disease progresses, like cognitive decline. It can be mild cognitive impairment or frank dementia, hearing difficulty, dysautonomia, RBD, anxiety and depression, mild olfactory deficits. So if we see the genetics of ET, positive family history is found in 20 to 90% of cases in various studies, and the mode of inheritance is autosomal dominant, as we all know. And first degree relatives of ET patients are 4 to 5 times more likely to develop ET. There are certain genes that have been found to be associated with risk of developing ET. These genes are being found in Jiva studies as well as familial linkage analysis. The LINGO1 gene, SLC1A2 genes are the most common. Other genes are ETM123, FUS, and HTRA2. These are the common genes. So these two are the most common genes that have been found in Jiva studies. If you see the pathophysiology of ET, there are several lines of evidence. So there is a case minute. I will come through that. Yeah, how the tremor diagnosis evolves. Yeah. No. Yes. So several lines of evidence have shown that cerebellar dysfunction is more prominent in patients with ET, with Purkinje cell loss, as well as increased number of torpedoes, that are swollen exons of Purkinje cells, and there are rhythmic activity in these two loops. So we can see there is a cortico-ponto-cerebello-thalamocortical loop, as well as this Gulian-Mollaret triangle loop. These two are predominantly involved, and apart from that, GABAergic dysfunction is also prominent. So reason behind we are using GABAergic drugs day by day. So now we come to the essential tremor plus consensus statement definition. So the first thing is tremors with characteristic of ET plus additional soft neurological signs of uncertain significance, such as impaired tandem gait, questionable dystonic posturing of arms, and memory impairment, or other mild neurological signs that do not fit into to make an additional syndromic classification or diagnosis. And ET with rest tremors should be classified as ET plus. So these three features. That duration classifies. नहीं सर, ET ना characteristic तो हुआ जो है upper limb tremors में.
आज plus one patient है. Follow for 5 years. आज मैं जो 5 years के बाद नहीं. तो ET plus से रखो तो
that debate will come, sir. That whether we should keep it as ET only or ET plus. Yeah. So these three features: impaired tandem gait, questionable dystonia, memory impairment, and ET with tremors at rest. So there were two studies, like they reclassified the previous patient in retrospective study, and they found that those who were initially classified into ET patients according to older classification, out of 133 patients, 110 patients went into ET plus. Yeah. Considering either one of the soft neurological signs. Yes. And there was another study from India, from Neiman's group. They also tried to reclassify. So 252 cases of ET were there according to older classification. They reclassified according to newer one. 64 patients excluded because of indeterminate tremor, because the duration was less than 3. And then ultimately 1/3 patients remained with primary diagnosis of ET. And it was considered that 19 ET plus was more common than ET in both the studies. So another case scenario. This is a 70-year-old male patient with a history of both upper limb tremors for 3 to 3.5 years with asymmetry, right more than left, and family history is positive in the father. Brain imaging is normal. So we can see there is dystonic posturing here in the left upper limb at the rest. Here also there is some, the tremor is more common in the right, there is some fanning of the fingers in the left. But the tremor amplitude is not that much high of characteristic of dystonic tremors. And there is asymmetry, right more than left. There is no position dependent change in the frequency of tremors. So considering there is one soft sign, that two soft signs, ET tremors at rest, and there is mild dystonic posturing of the left upper limb. And there is family history positive. And the duration is more than 3 years. So what should we consider in this patient, ET or ET plus for dystonic tremor? I have considered in this patient is ET plus because the dystonic posturing according to me was not that much significant, And his father had both upper limb tremors only, and there was no like dystonic posturing. I've seen the files like seen by another neurologist. So what are the actual issues with the ET plus terminology? So it is just a tentatively and uncertainly defined entity. It is defined slowly on the basis of clinical grounds. That is not based on differences in the etiology like genetic etiology or pathology or appreciable difference in the prognosis, and there is no biological basis for this terminology. And the soft neurological signs are of doubtful accuracy due to high rate of inter-observer variability. And there is no quantifiable metrics for this soft signs, such as to gauge whether a sign quantifies for additional diagnosis or not, like how much dystonic posturing should be considered to consider it as either dystonic tremor or ET plus, or how many missed steps in tandem gait should be considered as impaired tandem gait. And it also distracts, another thing, important thing is it also distracts the clinician from detailed evaluation of this kind of ET patients with additional neurological signs. So they can very well go into this two particular diagnoses which are very close differential of ET plus like SCA12 and Fragile X tremor ataxia syndrome. So it actually binds the clinician, that terminology ET plus binds the clinician to restrict from going further to investigate. So this is an interesting case.
Basically, there is no extra benefit on differentiating ET and ET plus.
Yes, sir.
So it doesn't give any history.
Yes, actually, and it is also creating a confusion.
Nor in prognosis, nor in progression of disease.
I think clinical nothing, but if you want to select pure ET, if you are worried that તમે mix નથી કરવું group. Research માટે.
Yes,
Yes,
research.
there should be some disease, why you should be.
But then researching also is difficult. So one example I will give you. There is a family of 8-10 members who have ET-like tremors. 5 patients have pure ET-like tremors. 1 or 2 patients have rest tremors, or maybe some dystonic posturing. Then research becomes also difficult. Nah? What to consider a whole family, like ET plus or dystonic tremor or ET only. So that is an issue in research also. This is a 40-year-old lady. Both upper limb asymmetric action more than rest tremors for 6-7 years. Family history is positive in father. I saw both the patients in the same city. So first I saw her. You can see there is a rest tremors in the right upper limb. It is there. So first soft sign. Then when there is asymmetry in the right more than left upper limb tremor are there. There is mild dystonic posturing is there in the third finger. But the jerkiness of tremor of dystonic tremor was not there. There was no position dependent change in the frequency of tremor also. It is considered a feature of dystonic tremor, but it was not there. And kinetic tremor was more than postural tremor in this patient also. So considering this patient, I thought initially maybe ET plus I'm going with the diagnosis. But then when I saw his father in the same sitting, here we can clearly we can see that there is significant amount of dystonic posturing in the right upper limb, and rest tremors are also there. And yeah, we can see there is neck posturing. Mild neck posturing. But in this patient, we can see there is significant dystonic posturing of both upper limbs as well as neck. So the diagnosis changes. So it becomes familial dystonic tremor. Yeah.
Mitesh, that is not more of a postural, I mean, this is a posture, right?
Yeah.
Rather than rest, I mean,
Yeah.
postural has no
રેસ component હતો ખબર
Rest component was there in both the patients.
Yeah.
But still in dystonic tremor also, action tremor is always more than rest tremor. Rest tremor will be more than ET, but still rest tremor will be less than action tremor. Both in both.
They put in the arms in
Yeah.
this position. That is the part of postural tremor.
No, this is rest tremor only. Either you can do like this or rest like this.
So if you ask the instructor to put like this.
No, that I'll ask the patient to keep it relaxed, not like this, but keep relaxed on the lap on the thigh. So this I have put a case unit of that how the tremor diagnosis evolves. So for example, a 55-year-old male with both upper limb action tremors of 2 years, positive family history in 3 generations. So at this point, what would be the diagnosis? 55-year-old male, 2-year history of both upper limb action tremors only.
after 2 years of
Indeterminate. So here it is indeterminate. But still we can't tell it as ET because the duration is less than 3. It maybe we can say that it is evolving ET. So then both upper limb action tremors at 5 years, no rest tremors still. Now we can say it is ET, right? So we can say familial ET. At 7 years, rest tremors appear, mild dystonic posturing and mild cognitive impairment. So what can we say now? ET plus. So it is familial ET plus. Then at 8 years, dystonia becomes more prominent. Now it is very obvious. So then we have to say familial dystonic tremors. And at 10 years, he becomes ataxic as well as other cerebral signs at 10 years. And now that comes into action. So because of positive family history in 3 generations, SCAR12. So this tremor can evolve like this. So the diagnosis gets changed. So we can see that pure ET can evolve into various other associated signs like Parkinsonism, ataxia, dystonia, cognitive impairment. Accordingly, various syndromes can be put, and there are evolving genetic syndromes which can be put in the patients who were initially diagnosed with pure ET. So if we see gait ataxia in ET, so we see pathomechanism of ET. There is enough amount of cerebellar dysfunction. So given this pathoanatomical changes, mild gait ataxia can accompany ET. It has been shown in several data. Similarly, dystonia also initially was considered as basal ganglia dysfunction, but now more and more amount of evidence is suggesting the role of cerebellum and basal ganglia connections. So considering the role of this pathways, some degree of dystonia, they hypothesize that some degree of dystonia can accompany ET over the long term. And likewise, dystonia has been increasingly becoming common in many spinocerebellar ataxias like SCA2, SCA3, and other SCAs. So that was an argument on the part of ET. Cognitive impairments, they have said that increased odds of developing MCI or dementia and more prevalent in those patients with late onset. Rest tremors in ET, 20 to 30% of patients, it is a feature of long-standing and severe disease. So that first patient, 15-year history, rest tremors is fine with ET. With the progression of ET, kinetic tremor worsens, rest tremors appear, and tremor spreads to other axial structures. So which is a better terminology? ET plus, ET with soft neurological signs, ET with additional neurological signs, or ET with red flags? That is a bit because confusing. Maybe we can say ET with additional neurological signs we can write, just not to stick into that particular diagnosis of ET plus. So that was the motive of this discussion. Then diagnosis of ET, it's a clinical diagnosis with comprehensive history and neuro examination. Routine laboratory tests should be done to rule out enhanced physiological tremor like thyroid antibodies, thyroid function test, electrolytes, RFT, LFT. And surface EMG and accelerometry can help identifying the tremor frequency, activation characteristic, and rhythmicity. But the limitation is that it is possible only in research setting. MRI brain to rule out secondary causes of tremor, and PRODAT scan particularly when we are confused between ET and early PD. Treatment of ET, decision making in tremor depends upon severity of tremor, functional disability, anatomical localization of tremor, whether tremors are only present in the limbs, only in the head, or combined. Other medical comorbidity and patient's desire to be treated. There are 3 types of treatment: medical management, botulinum toxin, and surgical treatment. Medical treatment, usually the first line of management in ET patients. It is indicated only when tremors are either socially bothersome or functionally interfering with ADL. And majority of pharmacological studies have they have focused on limb tremors only. And response to medication is variable. Approximately 1/3, 30 to 40% of patients do not respond to first line, second line medications. 1/3 to half patients initially respond, then they develop pharmacoresistance over long term. the dictum is start with monotherapy. If insufficient or partial response, go to polytherapy. So what is the evidence for treatment of ET? So if we see the level A evidence is only for propranolol and primidone, and also including long-acting propranolol. But if we see the MDS evidence-based review, that is a recent one, 2018, they have also included topiramate as efficacious and clinically useful, but only at a higher dose of 200 to 400 milligram per day, not at the lower dose. 5 studies were done, 4 studies were positive at 200 milligram and above, 1 study was negative, that was 50 to 100 milligram per day. If we see other medications like gabapentin, initially it was given level B, but now according to MDS it is suggested as insufficient evidence and investigational. Benzodiazepines like alprazolam and clonazepam also helps. Other beta blockers like atenolol, sotalol is also like possibly like level B evidence, so it can help in patients in which the side effects of non-specific beta blocker is there. Important points about propranolol and primidone: both are effective in limb more than head, more than voice tremors. Both reduces tremor amplitude by approximately 50 to 60%. Responder rate is 50 to 70%. Long-term response, the data is like that there is a data that shows that continued response over 1 year, but they usually require increase in the dose in both the medications. Both are equally effective as monotherapy. Lower doses of primidone, like 250 milligram per day, are equally effective as higher doses like 750 milligram per day. So there is no need to go to higher dose of 250 milligram 1 TDS or like that. Combination of both works better than either drug alone. Like if we combine both of them, then there is 70% reduction in the tremor amplitude. So if one is not effective or one is partially effective, add another one. Topiramate, useful as monotherapy as well as first add-on. Tremor amplitude reduction by 30 to 50%, higher doses, and dropout rate is high because of side effects. Benzodiazepine, good second-line treatment option as an add-on. Alprazolam has also been tested as monotherapy in one study that was positive. 25 to 35% tremor amplitude reduction is seen. It also reduces the anxiety, and caution is advised due to its abusive potential. Gabapentin is considered as second-line treatment, but below topiramate, and it improves tremor to mild to moderate range, and 1200 to 3600 milligram per day is the usual dose, but up to 1800 milligram per day is as effective as higher doses, like it was there in primidone. Medical management of head and voice tremors. Actually, no effective drug therapy except propranolol for head tremors. So if head tremor is there, try propranolol. It is of level B evidence. Then if no response, then go for Botox. Voice tremor, try primidone. There are 1 or 2 studies. If ineffective, go for Botox. Alcohol and essential tremor. So approximately 50% of ET patients respond to alcohol. Alcohol responsiveness, though it is not a pathognomonic feature of ET, because dystonic tremors, 30 to 50% of patients also respond to alcohol. Early onset ET, more likely to be responsive with alcohol, and there is high likely chance that rebound tremor with increased intensity, that is common after 3 hours of intake. Botox for ET, it is recommended for medically refractory tremor, essential tremor, level B evidence, useful for all 3, limb, head as well as voice tremor. Both are effective, Botox and Xeomin. There are 2 dose protocols, fixed dose protocol and customized dose protocol. So fixed dose protocol has high risk of hand weakness because of injecting extensor muscles of wrist. But otherwise, customized dose approach uses accelerometry or surface EMG or kinematic assessment, and hand weakness chances are reduced. It improves both postural and kinetic tremor, but not much improvement in the functional disability. Effect is maintained over 12 to 16 weeks, and customized approach is more practical because of avoidance of extensor muscles. Botox for botulinum toxin for head and voice tremors, it is of level C evidence. Head tremor, it has shown good improvement with injection. Injection into bilateral sternocleidomastoid and bilateral splenius cavities have helped. And the side effects are neck weakness or dysphagia. These 2 are the main side effects. Voice tremors, there are 2 class 2 studies. They have used bilateral versus unilateral approach into thyroid and arytenoid muscles. There is 50 to 60% subjective improvement in the tremor, but the side effects are more common, like transient breathy, weak voice for 1 to 2 weeks in majority, and hoarseness and swallowing difficulty are the other side effects. Surgical treatment. So it is reserved for the medically refractory tremor cases. The surgical therapy are of two types: lesional surgeries and neuromodulation. So lesional surgeries, there is a radio frequency telemetry, gamma knife telemetry, and MRI guided focused ultrasound telemetry. That is a newer thing. And deep brain stimulation, unilateral as well as bilateral. The most common target is VI and nucleus of thalamus, and there are other two targets also. So what is the evidence for surgical treatment? All are level C. Thalamotomy, unilateral, VIMDBS, unilateral level C, bilateral is level U because of high amount of side effects, and focused ultrasound guided thalamotomy is level C. So radio frequency thalamotomy, common nucleus target is VI and nucleus of thalamus. These all thalamotomies are done unilateral only because of high amount of side effect, high chances of side effect with bilateral surgeries. It is effective in suppressing limb tremor in 85 to 90% of patients, and effect is maintained well over long term. Side effects like contralateral hemiparesis, paresthesia, gait imbalance, speed disturbances are common, and those are more prominent with bilateral. DBS, the target mainly studied is VIM nucleus of thalamus. It disturbs the synchronous firing with VIM, and results from RCT are favoring, showing 60 to 70% improvement in tremor with functional disability improvement, and improvement is sustained over 5 to 10 years. And good results in ET plus cases are also reported with VIM DBS. Side effects, three most common side effects are paresthesia, ataxia, and dysarthria. Others are tonic muscle contraction, weakness, seizures, and decreased verbal fluency. Issues with VIM DBS, there is inconsistent improvement in head as well as voice tremor. Mainly it is effective for limb tremors. There is waning of effect seen in long-term studies of stimulation after around 5 years in approximately 50% of patients, and that has been attributed to either disease progression or tolerance to the stimulation, or the larger distance between the active contact and dentatorubrothalamic tract. And there is high risk of irreversible dysarthria and ataxia after bilateral VIM DBS. That's why it is level U in the AN guidelines. Unilateral versus bilateral. Bilateral is ideally more effective. If the patient has both upper limb tremor as well as head tremor, axial tremors, then bilateral is more effective, but the chances of side effects are high. VIMDBS versus thalamotomy. VIMDBS wins the race in this because tremor amplitude and functional improvement is better, side effects are fewer, and surgical complications are also lower with DBS. Other potential DBS targets are caudal zona incerta. Uncontrolled studies have shown greater effect than VIM DBS in zona incerta DBS, and it is sustained benefit has been shown up to 7 years. And posterior subthalamic area where the dentatorubrothalamic tract passes. These two are the potential next DBS targets for ET. MRI guided ultrasound focused thalamotomy. So this was approved by US FDA in 2016 for medically refractory ET patients in that is unilateral thalamic thermoablation using focused ultrasound under MRI guidance and stereotactic frame guidance into VI and nucleus of thalamus. So we can see from 1 month after this thalamotomy, the tremor score improved by 50%, while in the control group there was not much improvement. And here we can see the disability score at baseline, and at the 3 months there was much reduction, and it was sustained up to 12 months. Side effects are same, like paresthesia, gait impairment. These two are the most common side effects. And bilaterally, cognition as well as gait ataxia and speed difficulties are more common. Longest data is of 4 years. Similar to DBS, diminishing efficacy has been noticed over time because of decreasing lesion size or decrease in the perilesional edema or due to inaccurate targeting. And it has been stated that lesion larger than 170 mm, there are high chances of side effects. Treatment of ET plus, lack of studies due to poorly defined soft neurological signs. So currently it is managed in the same line of ET. We can try triaxiphenidil if associated dystonic posturing is there, and it can respond to VIM DBS if medically refractory. So this is what I have made one approach. So we can see the essential tremor. If the severity, according to severity, the tremor is mild, then we can opt for no treatment also. Or we can go for intermittent treatment in form of propranolol or alprazolam. Or if a patient wants to go, there is some mild disability functionally, then daily treatment in form of propranolol primidone and then second line treatment. But then if the moderate to severe tremors are there, And if elderly patients with or without comorbidities is there, then first should try primidone, followed by propranolol. And in the young patients without comorbidity, first propranolol, followed by primidone. If insufficient effect, then go for combination as the next step. If still insufficient effect, go for second line treatment like topiramate, and then alprazolam, clonazepam, and gabapentin. And after that, botulinum toxin and surgical treatment. If only limb tremors are there, can go for unilateral DBS or thalamotomy. If all tremors are there, like axial tremors plus limb tremor, then should go for bilateral limb DBS. And for axial tremors, head tremor, only propranolol and primidone we can try for mild to moderate tremors. Otherwise, go for either botulinum toxin injection or DBS in case of moderate to severe tremors in both voice tremors as well as head tremors. Emerging therapies, 1-octanol, that is a long chain alcohol that has been shown in uncontrolled studies to be beneficial. Another drug that is in pipeline is perampanel, AMPA receptor antagonist up to 4 mg per day that has been tested, and double-blind placebo-controlled study is going on for that. Customized dose approach for Botox administration, new DBS targets as I discussed, and non-invasive peripheral nerve stimulation like radial and ulnar nerve stimulation. These are the emerging therapies. Still, there are some unanswered questions about ET. So, how should we interpret the presence of dystonia in patient with ET? Can we improve the phenotyping of ET to achieve improved treatment response? What are the therapeutic options for patient with ET+? Should Botox be offered as first-line treatment instead of oral medications, considering the high level of pharmacoresistance as well as non-responsiveness? Is Beam DBS an ideal target for ET, and what are the long-term response to current intervention going on for essential tremor? So these are still unanswered questions. Now go for dystonic tremor. Dystonic tremor is an oscillatory, rhythmic, although often inconsistent pattern movement produced by contraction of dystonic muscle. So that inconstant thing is important. Two types of dystonic tremor are there. If the tremor occurs at the same site as dystonia, then it is dystonic tremor. And if the tremor occurs at a different site than other than involving dystonic region, if the patient has cervical dystonia and the patient has tremor in both the arms, then it is called tremor associated with dystonia. If a patient has, then I will go to the example. So this lady, you can see there is neck pulling to the left side and the tremor is the same side. So this will be called as dystonic tremor, dystonic head tremor with cervical dystonia, or we can say both, like cervical dystonia with tremors or dystonic head tremor. There is no tremor in the arm. Similarly, the other video, this patient, if you see, when he tries to speak, there is deviation of the jaw to the left and associated with jaw tremor. So at the same side, both things, tremor as well as dystonia. So this is also dystonic jaw tremor. And this patient had received metoclopramide twice or thrice, and then he suddenly developed these movements. And it is so disabling, and it is also difficult to treat even after Botox. So tremors in dystonia, dystonic tremor has to be differentiated from sweats as well as Parkinson disease with tremors with dystonia or ET+, and tremor associated with dystonia also should be differentiated from essential tremor plus. And there can be like that if a patient has cervical dystonia and postural like tremors in both the upper limbs, then it can be myoclonus also, like jerky myoclonus. So dystonia myoclonus is another consideration in this kind of patients. So that also should be differentiated. So tremor in dystonia is more common in patients with late onset dystonia, cervical dystonia as well as segmental dystonia. 80% of patients, dystonia precedes the tremor. Action tremor is always more than rest tremors, and it is a bit slower than essential tremors. It is usually less than 7 Hz. Characteristic of dystonic tremor, it is coarse, irregular, asymmetric, jerky, unilateral at times, and these two features, null point, presence of null point, and sensory trick. And directional quality, like frequency changes with change in the direction of the hands. So this patient is of 55-year-old male with both upper limb tremors for 6 to 7 years, and right more than left, action more than rest tremors, alcohol responsive, and positive family history in 4 members from the maternal side. So we can see there is obvious dystonic posturing, rest tremors are there, asymmetric quality, and the amplitude of tremor is much more than previous cases of ET and ET+. And here we see that frequency changes with the change in the direction of the hands. So that is a characteristic feature of dystonic tremor. So this was a familial dystonic tremor case. I did his SCA12 study also, that was negative, and whole exome sequencing was also negative. So single gene still have not been identified, like in certain kind of cases. There are some things that will come through. Head tremors in DT are multidirectional usually than unidirectional. They have rotatory component, and it persists when patient lies down in supine position unless there is null point in that neutral position. And these two characteristics should always be looked for. So this is a case of, so we can see there is, so here we'll see, so then there is directionality of change of directionality. One direction, then another direction. So this is one of the characteristic of dystonic tremor. Pathophysiology, initially it was loss of surround inhibition like dystonia at cortical and subcortical level, imbalance between the direct and indirect pathway leading to excessive stimulatory output. These two were older pathophysiologies, but newer ones are like dysfunction in the cerebellar burst neurons and those two loops like corticostriato-pontothalamic loop and cerebello-pontothalamic loop dysfunction. Now it has become more prominent in patients with dystonic tremor. These are certain genes of genetics of dystonic tremor like ANO3 genal mutation. Both can present as isolated familial dystonic head tremor. So with positive family history, dystonic tremor, these two should be particularly looked for. Even THAP1, I think Narendra has one case with THAP1 with prominent dystonic tremors, and TOR1, ADYT1. This also should be looked for. Treatment, there are no controlled or randomized studies available. Majority of drugs tried have been unsuccessful. Medication response is only seen in 40% of patients. Modality of treatment are like drugs, Botox injection, deep brain stimulation, and thalamotomy. So if we see the medications, there are no guidelines, and there are only 4 or 5 medications like triaxiphenidil. We can try in the dose of 4 to 12 milligram per day. It is useful in hand as well as head tremors and primary writing tremor. Propranolol also we can try in 80 to 320 milligram per day dose. Primidone we can also try. Clonazepam in the dose of 0.5 to 3 milligrams. So it is more in the line of dystonia treatment, except these two, propranolol and primidone. Botox for dystonic tremor, particularly useful for axial dystonic tremors like head, jaw, and vocal cord, and primary writing tremor. A response in upper limb dystonic tremor is variable, and therefore it is reserved for medication refractory cases. DBS, there are no randomized study till date. It is indicated only when disability from tremor exceeds the risk of invasiveness. And the targets are main two targets, VI and nucleus of thalamus if there is more tremor and mild dystonia, and GPI if there is concomitant dystonic tremor and dystonia both are equivalent, then preferred target is GPI. STN is not well studied, but it has shown improvement both in dystonia as well as dystonic tremor to a certain extent. So this was one case with severe dystonic tremor. You can see long-standing tremor. Initially, it was considered as perimyoclonus dystonia, but the tremors were so severe, and there is dystonic posturing. So this is an ideal case scenario that GPI DBS can be considered in this kind of patients. And this was a patient from my fellowship. So this is approach that was considered from Canadian group of approach to treatment of dystonic tremor. So if the arm tremors are more than head and jaw tremors, then first medications should be tried like anticholinergic, primidone, propranolol. And if isolated head or jaw or vocal cord tremor, then go for Botox. If these are not responsive, then can go for unilateral or bilateral DBS, considering the presence of tremor in various characteristics. Like if in case of bilateral upper limb as well as head and axial tremors, then go for bilateral. Otherwise, unilateral can also consider. So summary is essential tremor is not a monosymptomatic condition. It's a syndrome or a family of disease. ET plus is still loosely defined term. We should look for other etiology of tremor if associated with soft signs. And management of ET has been more rewarding far than dystonic tremor. Thank you.
You said about VI and DBS. After long studying, you said there is this dysarthria ataxia.
So bilateral EMD is more dysarthria attention. Unilateral, there is transient, like it is reversible, but bilateral, it is there. And still it is debatable whether unilateral should be done or bilateral, because American and Canadian group still favors unilateral DBS, but in India there are certain centers where bilateral DBS has been done in Mumbai also recently, 1 or 2 cases.
So you should be careful.
Yes. If like tremor is more and we have nothing to offer, then we should explain at this. This can happen.